Well, hello and welcome everyone. It's nice to see some faces as you were joining. So I'm mainly a haemostasis and thrombosis and obstetric haematologist, but while I was a registrar, I became very interested in mast cell disorders, especially mastocytosis at that time, and that's expanded to an interest in MCAS, and I now have a monthly MCAS clinic. But as you can see, I'm getting pretty old. This is my 41st year working in the NHS. And so in the near future, I'll be winding down. But I'm hoping to do some further research within this area before I do that.
Hi, I'm Chloe. I'm a dietitian. I've been working in the NHS over 10 years. So I work in the NHS and also have my own private practice. So I generally specialise in gut health. My interest in MCAS has really come through my husband's journey. So he found out he had MCAS about 6 years ago. And then with COVID, I'm seeing lots and lots of patients in my gastro clinics in the NHS with MCAS who have developed it or it's got worse, but Bethan will talk lots more about that. So yeah, that's me.
Hi, I'm Joy and I run the charity Mast Cell Action. So I work with an amazing team of volunteers and a group of trustees who will beaver away very hard in the background to try and help people with MCAS. So I've been working in the charity sector for about 10 years. I've been with Mast Cell Action as a volunteer for about 7 years, but I've been working here now for just over a year. I also have MCAS and I have 2 children with MCAS as well. So I've got a really thorough understanding of what it's like to live with.
Okay, so the majority probably know at least a little bit about the definition of Mast Cell Activation Syndrome. So it is an immune disorder, and the mast cells are activated by various triggers, and that varies from person to person. Might speak a little bit more about that later on in the talk. But let's think about mast cells themselves first of all. So they're a type of white cell formed in the bone marrow, which then migrate to the tissues where they have a protective role. So if you look at the top right, hopefully you can see at least part of the pictures there. There's an electron micrograph, and you can see that it's a round mononuclear cell filled with granules that occupy most of the cell, and they have numerous cytoplasmic projections which connect with other cells, quite often nerve cells. And the pictures below show mast cells in the bone marrow. At the bottom, a rare circulating mast cell. I don't know whether we can move the our individual things. Perhaps I'll move it so you can see those. Is that better? I think that would be better. So at the bottom there is a rare mast cell circulating the blood. So these have a soldier type role. They're patrolling the host environment interface, and those packed-in granules contain the mast cell mediators, which we'll talk about in the next slide. So next slide, please. Okay, so mast cells release both preformed mediators like histamine, and also they do synthesized mediators like cytokines and chemokines de novo from the start. And if you look at the picture on the right of the screen, this shows that mast cell receptors, and they can cause both non-immune and immune activation. So thinking on the right side, as far as I can see, the immune activation includes a whole lot of receptors, including FC receptors, stem cell factor, C5a, which is a complement receptor, MHC and the FC components that link into antigens. And on the other side, the non-immune reactions include toll-like receptors, which are involved in the recognition of pathogens and actively initiate immunity. And mast cells both produce platelet activating factor, PAF, and are also activated by it. They have estrogen, progesterone receptors, and are more easily triggered when estrogen levels are high. Opioid receptors are the reason to avoid codeine and morphine and some other medications from other similar receptors. The MRGPX2 is a relatively newly discovered receptor, and it stands for Maz-related G protein coupled receptor member X2. Not a very catchy name. So that's a relatively newly discovered receptor on skin mast cells, and it is involved in activating pseudo-allergic reactions. Next slide. So on this slide, you've got a summary of the main effects of the mediators, and that's the effect on the tissues and the body. So you can see that inflammation and swelling occurs for most of the mediator groups, but there's also the result of increased mucus secretion, blood vessel dilatation, smooth muscle activity in many organs and tissues, and restructuring also occurs with sometimes formation of lumps on the skin and other new vessel formation. Next slide. So let's consider the information we use to diagnose mast cell activation, putting together the pieces of a jigsaw puzzle, essentially. Next slide. So mast cell symptoms occur in a number of different areas within the body. Next slide. So, so they can occur throughout the body systems as the mast cells are ubiquitous. And patients often find it helpful to look at a list of potential symptoms, like on the left of the screen, and then they realize that there are more systems involved than they thought sometimes, but everyone is different. And also symptoms may change over time, waxing and waning or gradually increasing over time, and often related to external events and underlying causes, some of which are listed here on the right. Next slide, please. So the Mastocytosis Society in the US surveyed over 1,500 individuals with MCAS in 2019 and demonstrated, firstly, that 8 out of 10 had fatigue, intolerances to foods or chemicals, brain fog and abdominal pain. 7 out of 10 had flushing, muscle and joint pain, hay fever or other environmental allergies, pruritus and bloating. And 6 out of 10 had blood pressure changes, nasal congestion and itching, fainting or lightheadedness and diarrhea. Next slide.
This slide represents our family. So I mentioned earlier that myself and both my 2 children have MCAS. I was diagnosed much later on. My daughter was diagnosed at age 7 and my son at age 10. And despite obviously there being a crossover, we all have very different symptoms which are unique to each of us. And again, very, very different triggers. To give you an example, my daughter is the water, being in water is the only thing that helps sometimes when she's very itchy, whereas my son responds by getting itchy when he's in water. So despite the fact there's obviously some sort of crossover, this demonstrates the vast difference that we see in symptoms between patients. So even if there is potentially a genetic link there, We all had the positive urine test, which we'll talk about later on, with excess mast cell mediators, but they were at different levels and different mediators. And this is the symptom log that we've created as a charity. So the idea being that because it's so complex to try and isolate the different symptoms that you're experiencing and the different triggers, this gives you a resource to be able to track and isolate what those triggers might be, what might be causing those symptoms, to also track medications, any reactions to medications, and any other observations that you're having. So the idea behind this is that it has been formulated to help you create a plan by seeing which triggers your patients respond to and which symptoms they're having. And these are available to download for free on our website, which we'll share the link later on and in an email to you later.
So anaphylaxis can be a symptom of MCAS. So in isolation, also a lot of my patients may have a primary allergy alongside the MCAS, which can make it really confusing whether they've been exposed to that primary allergen or they're having an anaphylactic reaction as a result of their MCAS. Can everyone make sure their microphones are off, please?
Mast cell, please.
Thanks. Anaphylaxis is a serious allergic or hypersensitivity reaction which has a rapid onset, and it affects multiple body symptoms generally, so ABC, airways, breathing, circulation. However, saying that, I would say, as with anything to do with MCAS, there's a lot of grey, so there's a lot of sort of atypical anaphylactic reactions. My husband after COVID had a sort of anaphylactic type presentation. His lungs filled up with fluid. He had circulation issues, but he didn't have that typical airway closing up over the throat symptom that you would, expect to see during anaphylaxis. There is a lot of grey. A lot of my patients carry EpiPens. There's loads of different triggers, and we'll talk about the general triggers for MCAS later, but it's just to be aware that anaphylaxis can happen in some patients and not everyone, a bit like looking at Joy's family, sorry, can I just ask again that everyone's got their mics off because it's really distracting.
Veggie fingers.
You can go on to the next slide, Joy, thanks. So common MCAS triggers, so on here we put it's not just food that can cause your histamine bucket to overflow, but as Dr. Myers has explained, of course, it's not just histamine that's produced by these mast cells, so it causes all of those chemicals to overflow. So I think it's really, really important to emphasize this to patients, just because food is often something you can control. So often food gets restricted, but actually you need to think about overall triggers. So for example, we went to Mexico on our honeymoon. My husband got loads of insect bites. He was also drinking alcohol, having loads of high histamine foods like avocado and pork, and had a massive reaction. Whereas if you'd taken out one of those factors, or maybe you'd just been doing one of those things, then maybe that reaction wouldn't have been so massive. So it really is really important to look at everything that's going on rather than just food. Things like hormones. So I see patients whose food triggers actually change during the month. So in the week before and the week of people's periods, with the fluctuations in estrogen, people can become a lot more sensitive to food in some cases. So looking at that cycle can be really important in trying to open up people's diet when they're less sensitive to the foods. You can go on to the next slide. Thanks, Joy. So the histamine bucket theory is one that I spend my life talking about. Really good analogy of how you can try and balance out MCAS symptoms. So as I said, there's lots of different factors that can contribute, and actually if some of these environmental factors are lower, then you have more room for dietary triggers. for example, in pollen season, pollen is already going to top some people's buckets up, maybe half full, 3/4 full, and you've got a tiny allowance then for things that might top up people's histamine levels, such as diet. Whereas, you know, in winter season, when you might not have that pollen exposure, you know, some people can eat a lot more varied food, a lot higher histamine food than they might do when they're exposed to all of those environmental triggers. So looking at that bucket and letting people be flexible with their lifestyle and what they're doing, and try and keep some of those factors lower that are going to fill that bucket, can be really helpful.
Okay, coming back to the MCAS jigsaw puzzle of diagnosis, the first was the multiple different symptoms, at least 2 and often a lot more. The second thing is the response of symptoms with MCAS treatments. Next slide. So, sorry, it's a busy slide, but I wanted to get as many mast cell treatments on this as possible. So if we run through from the left-hand side first, so mediator blockers, the classic first line for mast cell activation syndrome are H1 and H2 blockers. And often some patients will respond to some of the H1, but not others, and similarly with H2 blockers. Prostaglandin blockers, we don't often use aspirin because often that does cause reaction in and of itself. But other prostaglandin blockers, such as non-steroidals and steroids, often I use an inhaled form of steroid now that we don't have the Intal inhaler. And another mediator blocker on here is anti-leukotriene. So montelukast is the classic anti-leukotriene medication used in standard treatment for asthma, but also for mast cell activation. Mast cell stabilizers include sodium chromoglycate, and that's in a capsule form. It wasn't an inhaled form, sadly no longer available. Opticrom eye drops are sodium chromoglycate. You can also open the capsule and mix the contents with a lotion that doesn't have anything that you might react to, and put that on the skin to calm skin mast cell reactions. And some patients who have a nebulizer are also able to use the Opticrom in that successfully. Vitamin D is an important mast cell stabilizer as well, and getting that into the system if there are gut issues. I usually suggest to have it either sprayed into the cheek or under the tongue, so it's absorbed directly. Ketotifen is available in a tablet form, a liquid form, and eye drops. Some people react to the tablet form because of fillers, reacting to the fillers in the tablet, and if that's the case, we change to the liquid and see if they respond better to that, and also use the eye drops. And both the sodium chromoglycate drops and the ketotifen drops can also be used if there are external ear symptoms, and that is also another calming effect. And then there are some novel anti-inflammatory agents. So over the last couple of years, I have mugged up about low-dose naltrexone and used it pretty successfully in a number of patients with mast cell activation. You start very gradually, as with any other medication in somebody with mast cell disorders, and gradually increase to a maximum tolerated dose. So again, if there are reactions when somebody takes it via the gut, I suggest trying to take it under the tongue. There is a sublingual preparation and a liquid preparation. Obviously, it's hard to hold the liquid preparation under your tongue, depending on the volume. But a number of patients have found this a successful way when they haven't tolerated taking it in the standard way. And then a couple of other agents which are anti-inflammatory, but fairly new to the UK, but used in the States. One is PEA, or palmitoyl ethanolamide, which inhibits neuroinflammation, which is really important because the mast cells are in the brain as well as everywhere else. And quite a number of patients will have depression or other brain-related symptoms. And modified citrus pectin is also an anti-inflammatory agent. You might be familiar with the bioflavonoids such as quercetin, and you have to combine that with vitamin C for good absorption, or luteolin. And there's a combined medication as well that can be used combining various bioflavonoids. DAO enzymes, I think Chloe might talk a little bit more to those later on. We find it quite helpful for, especially if there is dumping symptoms in the night with increase in sweating, and it seems to, if it's taken late in the evening, sometimes that has a calming effect. And vitamin C is important because that increases the diamine oxidase in the body. There's recent studies showing that Xolair, or omalizumab, is a useful drug in mast cell activation. So quite a few of my patients have had this because they've had anaphylaxis or severe urticaria. But now we know that they also respond very well to omalizumab simply with mast cell activation. Clearly, it's difficult. As a hematologist, I don't have access to it. The allergy team and dermatology teams do. But everyone responds differently to these medications, and some may be contraindicated. And you have to remember that when you use a tablet, there may be excipients in that which are causing the trigger symptoms, not the actual effective component. And then looking to the right of the screen, there's a very recent article which is very interesting, I think. So circadian rhythms are very important for health. So every cell has a body clock. The super chiasmic nucleus in the brain controls that as SEN at the top there, and that's the central clock that governs the rest. And during the daytime, mast cells contain fewer receptors for IgE and IL-33, which decreases the sensitivity of mast cells to degranulation. But at night, the receptors increase, making mast cells more sensitive to degranulation. And it's likely why mast cell activation and allergic symptoms are highest at night. But if that mast cell clock is disrupted, then daytime mast cell activation resembles the state at night and becomes more sensitive to activation in the daytime. Next slide, please. So the third aspect of diagnosis is to look for some biochemical abnormalities. Next slide. So in the UK, in the NHS at least, we don't have many tests. Serum tryptase is a common one and easy to do, but in the majority of patients with mast cell activation, it appears to be within the normal range or sometimes at the lower end of the range. But it will be elevated in people with hereditary alpha-tryptosemia, recently diagnosed mast cell condition in 2014, and also raised in mastocytosis. So some patients will both of those conditions will have very similar symptoms to MCAS patients, and there's a considerable overlap. And the other thing that we're able to test in the NHS are urinary N-methylhistamine and prostaglandins DM-E2 and F2 alpha. And elevated results in these are suggestive of a diagnosis of MCAS. There may be other conditions that mimic this, but often it is supportive as a diagnostic test. When they have normal results, I don't consider that to rule out MCAS if the patients have multiple symptoms in different body systems and also respond to mast cell stabilizers and mast cell mediators. But locally, we save a urine collection over 24 hours usually, or a spot sample if the patient has symptoms at that time. And we send it off to Sheffield Northern General. And there is a sheet on the right here with their information. Next slide. So this slide shows the information that we give to patients regarding the 24-hour urine collection to enable it to be as good as possible, because these mediators do disappear quite quickly if they're not kept chilled. So we give this information to patients. Next slide. So, and the fourth part of the puzzle is to exclude other diagnoses. Next slide. So on the left, looking at the left, first of all, this is a challenge in diagnosis to exclude other conditions because there are overlapping conditions, but they may better explain symptoms if you do specific tests. But some symptoms are very non-specific in a lot of conditions, such as brain fog and fatigue. In haematology, for instance, we have antiphospholipid patients who overlap with MCAS because they have brain fog, fatigue, and lots of other symptoms. And sometimes we're able to demonstrate the raised prostaglandins in their urine. Gut disorders, there are, again, mimicking symptoms like functional dyspepsia, irritable bowels, histamine intolerance, and even anorexia nervosa that need to be separated, but there is, again, significant overlap. And rare tumours should be excluded, such as pheochromocytomas and carcinoid syndrome. And sometimes Addison's disease with low cortisol can be a separate condition, but mimicking, again, the symptoms of MCAS. On the right, we've got a very broad sheet of lots of other mimickers, if you like: cardiovascular, endocrine, gastro, infectious disease, neurological, cutaneous, hematological, and drug-related. And you'd be able to see when more information about that when we release the slides. Next slide. So we need to think about those comorbidities associated with MCAS. And as I've said, they're often general and can overlap with other conditions. And many people have more than one condition. And on the right here, you can see the list. So fibromyalgia, connective tissue disorders, particularly HEDS or Marfan syndrome, dysautonomia, or postural orthostatic tachycardia syndrome, POTS. Occasionally, Kunis syndrome, causing cardiovascular symptoms, and then more general symptoms overlap is long COVID, multiple chemical sensitivity syndromes, ME or chronic fatigue, Lyme disease, post-traumatic stress disorder, irritable bowel, Crohn's, celiac, interstitial cystitis, and bladder pain syndrome. On the left of the screen, there's a small picture. On the next slide, this is enlarged so that you can see more detail. So this links to the many comorbidities that can be associated with MCAS, and symptoms are overlapping on this slide. So if you look at A, in peripheral nerves, mast cells can localize to either the epineurium, perineurium, or endoneurium of the nerve cell and release mediators which may activate nociceptors, causing pain, peripheral neuropathy and headaches. At B, there's upregulation of the mast cell cytokines, and that can lead to dysfunctional fibroblast proliferation in nasal and bronchial tissues, causing rhinitis and sinusitis. At C, mast cell-induced TGF-beta upregulation in esophageal tissue results in bronchial smooth muscle localization and eosinophilic esophagitis in D. And then at E, the microenvironment changes to the extracellular matrix, inducing IgE-mediated autoreactivity, rheumatoid arthritis, and SLE. And finally, can also contribute to laxity in the blood vessels, causing pooling of the blood in the extremities and contributing to POTS. Next slide, please. So moving on a little bit to the association between long COVID and MCAS. There were several studies done. This one is from the American group led by Larry Afrin in 2020. And he and colleagues demonstrated a significant overlap in symptoms between long COVID and MCAS. And also that the mast cell treatments were helpful in long COVID. On the right, the highlighted symptoms are clearly similar to mast cell symptoms. And this was followed by another elegant study led by Lenny Ranstock on the next slide. So they recruited adults from a long COVID group online to do an assessment of symptoms pre and post COVID. They had 136 mostly female cases with long COVID, 136 controls, again mostly females, and about 80 MCAS cases, and again 85% female. So if you look at the spider plots, pre-COVID, long COVID subjects were very similar in pattern to the general population. So those two plots on the left of the screen overlap each other in similarity. And post-COVID, long COVID patients, their pattern mirrored MCAS prior to treatment, those two on the right. So they concluded that increased aberrant mast cells induced by the infection of COVID underlies at least part of the pathophysiology of long COVID, and which suggests routes to suitable treatments similar to those that we use for mast cell activation syndrome. Next slide, please.
I've literally just been telling someone on chat how rubbish I am with technology, and I'm still muted, so sorry about that. So self-management of MCAS. At present, there's no cure for MCAS, and the aim of treatment is to reduce the frequency and severity of symptoms. I'd say a bit like long COVID patients, people find it a bit like a roller coaster, whereas they can be stable for a while and then something else comes along, like another illness, and sometimes that causes another flare-up. So people, even if they're relatively stable, can still have flare-ups. But in terms of self-management, it's so important to identify triggers. So environmental, foods, stress and how to manage that, change in temperatures. A lot of my clients at the moment are really struggling because of the heat, and if they've got co-occurring POTS as well, then it can be a real struggle. Exercise, so not everyone is going to have the same triggers. They can vary so widely, so it's really important to work with clients to identify their individual triggers. You can go on to the next slide. Thanks, Joy. So again, although diet's the first thing people think about, only one source, so actually getting people to think about, you know, what cleaning products they use. Some people are really sensitive to things like smells and air fresheners. Joy's told me before about hotels they've gone to as a charity where they've, you know, asked people to watch for air fresheners and things like that, and make sure when you're going into other people's homes, and those sorts of things can be really hard for people to control, and also a really difficult conversation to have with someone. So emotion, stress and tiredness can play such a huge role, and it's a really vicious cycle. So often when people find their mast cell mediators are high, it does affect their sleep pattern, and then that can lead to more tiredness because they're not sleeping well, and it can be really hard to get out of that. So actually talking about, you know, things like sleep hygiene and stuff like that can be helpful for some. Next slide, please. So MCAS, dietary self-management, and it says self-management. However, you know, these clients often need a lot of support. Often the types of diets they're doing are really complex. There is no one official diet for people with MCAS. However, the majority of people do find some benefit from reducing the histamine in their diets if following low histamine diets. The elimination diet, so this slide talks about removing the food group for a period of 6 weeks. However, if I was doing a low histamine diet with someone, I'd really look at 2 to 4 weeks. There's absolutely no evidence behind, you know, the period of time that is done in this patient group. However, with a lot of clients, I find that once foods are removed, it can be really difficult to get it in, you know, number of reasons. Either they become more sensitive to it, but also the fear becomes quite a lot more as well because of the severity of the reactions they've had in the past. And then it's important to guide people through reintroducing foods one by one to see if there is a reaction to an individual food. Other diets definitely are used, so things like low salicylate, other food chemicals. So one I was introduced to by Joy was the RPAH diet from Australia, which I actually use quite a lot now. So that eliminates food chemicals, so histamine, other amines, salicylates and glutamates, and then reintroduces them to see if people are sensitive to them, and can be really helpful. Low FODMAP isn't on this page anyway. Well, actually, yes, it is. So it says some specialist diets including low FODMAP, but actually if people have a sensitivity to histamine in the diet, the low FODMAP diet can make things much worse, because foods that are low in FODMAP, like tomatoes, for example, are really high in histamine. So early in my career, I was seeing lots of patients with IBS put on the low FODMAP diet, and they were saying, you know, my symptoms are actually so much worse. Tomatoes are a trigger. And looking back, that probably was the histamine content in those foods that were making these people worse. Next slide, please. So histamine breakdown in the body, Dr. Myers briefly mentioned earlier diamine oxidase, so DAO, and that's the primary enzyme that's in our guts that degrades histamine in the food we eat, or the histamine produced by our gut bacteria. Some people with MCAS, that enzyme might also not function as well as it should, might also be reaching full capacity because of the amount of histamine that is in the body, and DAO enzymes may be helpful for some people. So you can buy them online. In Europe, they're a food for medical purposes. It's best to take them 20 minutes before a meal for them to be most effective. The directions on most packets say take 1 before each meal, they're really expensive. So some clients decide to just take them, you know, if you know you're going out for a high histamine meal when they go out for dinner. However, obviously, if they're taking them regularly, then it might help to reduce the histamine bucket generally. So obviously, I leave it up to patients' choice if they are finding them helpful, how they want to use them. It's also really important to remember that although histamine can significantly contribute to MCAS symptoms, and one study showed it was the most important chemical that contributed to the majority of symptoms, it's only one of the mast cell mediators which causes physical changes. So these supplements aren't going to cure every single symptom, but might make things a little bit more tolerable. Next slide, please. So high histamine foods. High histamine foods are just everywhere in lots of social foods that we eat. So chocolate, cheeses, cured meats, alcohol. Some foods like strawberries, they talk about them being histamine liberators. Actually, you know, there's not much evidence that histamine liberators do what they say, as in get our bodies to produce extra histamine. However, some people might still find they are sensitive to them. So even if a food says it's high histamine, it's still really important to try and introduce it, because everyone's going to have different food triggers. So my husband reacts really, really badly to sourdough, to the point of calling an ambulance, which as a paramedic is just not what he wants. Whereas I have patients that can eat it, you know, and say they tolerate that better than normal bread. So it really is individual and working with individual patients. So things like coffee, but it is impossible to eliminate all high histamine foods. And when we're talking about the low histamine diet, we are talking about a low histamine diet and not a no histamine diet. So it's important for people to have awareness of the histamine in food, but it really is impossible to measure exactly how much histamine is in each food, because it depends on storage and transport and many different factors. So there is no one gold standard list. They vary massively. I have patients that follow the SIGI, the Swiss list. There's the Australian RPAH list. There's the British Dietetic Association sheet. And there is not one that I could say is, you know, 100% accurate. There are more reputable ones, but yeah, it can be really, really confusing for patients. Next slide, please. I talk about hidden histamines with patients just because there are obvious ones like tomatoes and chocolate, but there are also ones that are more food additives that kind of creep into food, and they might not be a problem on their own, but if you have lots of them, then it might build up and overflow that histamine bucket. So things like yeast extract is in absolutely everything. So things like crisps and gravies and sauces, tomato powders, also in things like spice mixes, leftovers. So the longer a meat is left out, then the more the histidine in them is degraded by bacteria into histamine, and the more histamine there is in leftovers. So often I encourage people to freeze leftovers as soon as they can after cooking, and then using it on the day. And things like soy sauce, anything that's fermented, people don't necessarily think of just because you think you're using a tiny amount of sauce, but actually if you're using it throughout the week, it can really build up. Next slide, please. I always want to go down the less restrictive option, and I think my job as someone that specialises in MCAS is actually trying to get people to eat more foods and be able to tolerate more foods. Obviously that isn't always possible without medical support, but that is the goal. So if we can look at first line low histamine advice first and see if the less restrictive option can work, then great. So making sure food is as fresh as possible. So some people go to the butchers and ask for them to have as fresh meat as possible. There's certain fish retailers online that sell fish that is frozen on the boat, so it reduces the histamine levels in that. Obviously those things aren't accessible to everyone, so you know, I often discuss choosing the longest date in budget supermarkets, freezing it as soon as you get home. If you're going to use it a week later, then defrost it when you're going to use it, rather than let it sit in the fridge all week. and maybe consider removing 1 or 2 high histamine foods to begin with, especially for those people that you think are really going to struggle with a restrictive diet. For example, you know, in the UK we use loads of tomato-based sauces, so would actually reducing that help? Next slide, please. So I get asked this a lot, does cooking affect the histamine content of food? So it's not really going to make much difference, and actually you're better at looking at what types of food you're eating rather than the way you've cooked it. I think it's really confusing as well. So boiling certain vegetables may reduce the histamine content, but actually it can increase it in others. And actually one study looked at the histamine content in grilled seafood and meat, and this increased it compared to boiling these foods. However, you know, they're one-off studies. I don't think we have enough evidence to say, you know, if you cook the food in this way, this will definitely help. It really is, you know, working with the individual patient. Next slide, please. So there's loads of difficulties faced by these patients that follow the low histamine diet. So the struggle to find reliable information, loads of different lists online. Actually, if you're picking foods from every single list, you're ending up on a much more restrictive diet than you need to. It can be really socially and nutritionally restrictive if it's not well planned. So you can't just walk into a restaurant and say, can I have a low histamine meal? You're not going to understand it. So actually phoning up restaurants in advance can be really helpful. There's also going to be loads of other tips on a self-management project that Mast Cell Action are bringing out. So that can be given to patients to help with the social restrictions with that. Diet is unlikely to help on its own. You need lots of other tools in the toolbox to help. There's also cost implications. So a lot of people end up paying privately for medications, for medical support, for all these supplements. And also if they're having to, you know, source fresh food as fresh as possible, and they find they can't actually tolerate supermarket food, then, you know, the cost implication can be huge. It can also feel really isolating that no one understands the diet of the condition. Even as medical professionals, we've really struggled to, you know, navigate our way through this. And my husband doesn't often like speaking to a lot of health professionals, sometimes even being a health professional himself. And that's from someone that, you know, understands the system. So it can be really, really isolating for patients. And eating out and traveling can be really difficult. Next slide, please. Sorry, I just went to clip. But it's not all doom and gloom. You can definitely overcome the difficulties with support. So with a low histamine diet, finding a dietitian who can support you with a low histamine diet. There's some really helpful accounts on Instagram. So Low Histamine Kitchen, and she's got a website as well, Through the Fibro Fog, and she's got some amazing recipes. And also Positively Chronic Travels on Instagram looks at living with chronic illness and traveling, which can be really, really helpful. We're also launching the self-management kit by Mast Cell Action, and that's going to look at some things like eating on a budget on a low histamine diet and traveling, and things that might be helpful. With the feeling of isolation, so Mast Cell Action are doing some amazing events and community Zoom sessions, the Facebook support groups, weekly Tai Chi sessions. So if you have anyone you think will be interested, then send them over to the Mast Cell Action website and get them involved. Next slide, please. So there's loads of meal ideas, and I really am going to whiz through because it's 5:02. But if anyone wants any meal ideas, then feel free to email me. There's lots of breakfast people can eat. It just takes a lot of planning. And especially if people struggle with the fatigue side of it, it can be really hard to get quick food that is also low histamine. But on screen, you can see some breakfasts that would be suitable. So if you want to skip through. Lunches, soups easier in the winter rather than this really hot heat. Salads with suitable stuff. So yeah, there are options. And evening meals. It definitely becomes easier the longer you do a low histamine diet. So I've been cooking for it for about 6 years, and we learn all the time. and it's definitely got easier, but that's not to say it's not still a struggle sometimes. So this is MCAS low histamine toolbox, just with some of the things that might help. The only thing I probably haven't talked about is probiotics. So there's some studies that look at histamine intolerance and probiotics. And I guess it's important to talk about, just because some gut bacteria can produce histamine and some can help us break it down. And actually, if you've got MCAS, where your mast cells are producing all these excess chemicals anyway, and then potentially you might have an imbalance in gut bacteria, and some of these patients are getting loads of gut symptoms anyway, that is probably when I would talk about probiotics, and ones that might have strains that might be suitable for histamine intolerance. So yeah, next slide.
Hello, sorry, I was answering some of the questions. So during COVID, although I carried on going into work, it was a time where there was a little bit more time to think about alternatives to standard treatments. And I looked into quite a few of these things. So we know that the brain has the big impact on the body. So it's really important that we say to patients, this is not all in your head. And I start off saying that if I'm going to suggest anything like this, I say, I know that these things are going on in your body, but that the mind also has a part to play, an impact on what goes on in the body. So I've been studying a little bit about heart rate variability. It's quite an in thing now, and heart rhythm coherence helps restore the regulatory capacity and has a calming effect. Vagal nerve stimulation, there's one product called Sensate, which also has a very calming effect. I have something called an Apollo wearable, which has low frequency sound waves, which are felt as a soothing vibration. You don't necessarily feel the vibration, but it has an effect on the parasympathetic. So that reduces stress, which even as physicians, we all have, apart from the patients. The Gupta program has been beneficial for at least one of my patients, and it's a series of brain training exercises, and it's been successfully used in long haul COVID, MCAS, and multiple chemical sensitivities. Earthing and grounding are really, this is to do with the Earth's magnetic fields and our own connections with that. The Earth has a massive supply of electrons, and that can have a very positive effect on our bodies as well. Brain tap is another deep meditative brain states that's produced. You wear a headset and you have audio sessions with brainwave training, with light, sound and vibration, and they match the brainwave frequency of alpha waves. So again, that is a very calming entity. I've also been studying quantum physics, the bioenergetics of the body. And again, this is to do with a magnetic field, not only of the Earth, but the magnetic field that's around our bodies. And this can also have quite a calming effect on some patients. And I have been using that in a few of my own patients. There are lots of other things I haven't put on this slide simply because it would just get too crowded, but we will add them into the PDF at the end. But just one extra thing that I want to mention, there's an excellent book which is about EDS, mainly hypermobile EDS, and it does talk about mast cell activation and POTS as well. But a number of the patients, lots of patients will have EDS as well as MCAS, and it's really a detailed and helpful book. So we'll make sure that that is much more clear than the picture shows on the PDF. I think that's the end of my slides.
Thank you. So the tools and resources that we've been working on as a charity have been designed to fill the void that we've seen with people coming to us. So we noticed that there were, obviously lots of well-being issues with people feeling really low and struggling with their mental health, and so we developed a series of resources to try and support this. All of the resources are available to download for free on our website. The only one that isn't is the Casper the Chameleon pack. So Casper is a chameleon who has MCAS, and he's feeling really miserable about it because he's itchy and he's covered in bumps and he can't always join in with his friends. And then he starts to feel a bit better when he talks to his friends about it. And actually the pack was designed with a children's psychologist and a children's play therapist, and there's lots of information throughout the pack and exercises for families to do together to have what may be tricky conversations otherwise. And those are available to order for free, so you can direct people to us. If you'd like a copy for your clinic, feel free to send us an email and we'll post a copy out for you. So just a brief history of Mast Cell Action I thought would be good to share with you. So the charity was started in December 2016 by a group of people with MCAS who didn't really have anywhere to go and were looking for support, and realised that there was a real need, and has steadily grown over the last 7 years into a small team of trustees, lots of incredible volunteers working really hard to try and help people in the community. And that's really expanding this year with the sort of community offering that we've got. And our charitable objective is really simple, just to make life better for people with MCAS. And we do that through lots of different means and methods, and developing services, resources, working with health professionals to try and raise awareness and share knowledge and research. So if you've got an idea for something that you'd like to see us create to help the community, or if you've got an idea for something you'd like to work with us on, please get in touch, because we always love to hear from you. These are the contact details. Obviously, don't worry about writing them down, they'll be included in the PDF, and just the links at the bottom as well are for our Facebook support group. So we have an adult group, which is for obviously adults with MCAS, and then a parent support group as well. And I just briefly will mention fundraising for Mast Cell Action. Obviously, we want to do loads and loads of events like this and create more resources and services. So if you ever feel inclined, it would be wonderful if you choose to support us, cake sale in the hospital, or if you wanted to run a marathon for us or something completely different, just get in touch. We'd love to hear from you. And that brings us to the end of our presentation. So we can take some questions. I think there might be some things in the chat. So I'm